So without further ado then, I'd like to start with the first session where we're going to hear from Helen Duckworth, who is Deputy Director of Planning, Performance and Delivery at Liverpool CCG. She has joint responsibility for planning, prioritizing and performance managing of the NHS in the city of Liverpool. She also heads up the Liverpool CCG Business Intelligence team, which is a team of about 17 analysts that support all elements of intelligence in the commissioning cycle. And she's joined today by Benjamin Barr. He's a professor in applied public health research at the University of Liverpool. His research focuses on using natural experiments to evaluate the impact on health inequalities of both local and national policies. And since last year, he's also the head of the World Health Organization's Collaborating Center for Policy Research on Determinants of Health Equity. They're going to talk to us about the real-world intervention causal evaluation tool, also called RICE, which I'm sure they'll tell you a lot more about. So I'll hand over to Helen first, I believe.
Thank you, Arne. Excuse me, just clear my throat. Hi, everybody. So, yeah, next slide, please. So just a little bit of the structure of the presentation. I'm going to talk to you a little bit at the beginning about the kind of decision-making context. So what decisions does the Liverpool CCG need to make, and what are some of our processes to make those decisions? I'll also talk to you a little bit about data that's available to us and how we got to that position, because that really underpins then the work that we've been able to do to produce the rapid evaluation tool. So following that, then Ben's going to talk about the tool itself and what it does and how we've implemented that. And then he's going to pass back to me and I'll talk a little bit about the kind of so what. So how far did we get in really implementing rapid evaluation in the decision-making process? So next slide, please. Okay, so Arne kind of gave a nod to this, but in terms of the key stats for Liverpool, then it's a complex health system. So we've got a lot of providers, a lot of hospital trusts and specialist trusts. We've also got 85 GP practices, a lot of care home provision, and with a budget of just under £1 billion to allocate. There's also a lot of deprivation, and with that, some significant health and socio-economic challenges in the city. So there's quite a lot to go at in terms of our decisions on what we do. And the main thing really around our role of that in terms of the Liverpool system and my department's role is that, and CCG's role really is that we've got to allocate that £1 billion appropriately, and all the time we're making decisions about how to do that, be that to decommission or commission services to improve the health of our population or balance the books. And so a lot of what I'm going to talk about today is what is that decision-making process and how can we sort of embed evaluation into that. Next slide, please. So, this is quite a lot of detail. We probably don't need to go into the steps, but broadly speaking then, as you would hope for that £1 billion worth of spend, we have quite robust planning processes. So where we need to set in, where we've got an idea for a service change, or we need to put an idea forward to save money or improve the health outcomes of the population, that has to land in terms of a set of documentation. So Form 0, we call it as an idea. And then there's a decision, a planning group that meets. The next one's meeting on Friday. I chair that, and we make decisions about whether we take projects forward. So there's a mandate to progress through that process. That then moves on to an approval process. And from there, essentially, a business case is created that describes what the project is, the impact of that, all the various impact assessments, the financial impact, and the project completes a priority scorecard. And that's a set of criteria that then we use to prioritise against, and I'll come on to that shortly. Once that's been agreed to move forward through the prioritisation process, then it's mobilisation and implementation. So there's a lot of project documentation around that. And then we come right round full cycle then to the evaluation and recommendations. And there's quite a machine behind this, and we keep tweaking it, but it's got better over the years. But this is the process that we have to go through, our business planning process. Next slide, please. And so, as you would imagine, there's a lot of governance around that planning process. So we have the planning group that I've just spoken of that meets every 2 weeks, and that has a part A and a part B. The part A receives through the business cases, makes decisions about whether they move forward, and the part B looks at the monitoring once they've agreed to move into implementation. There's then a handover and oversight and governance to our SLT and our governing body. So as you can imagine, through this whole process, there's opportunities to embed evaluation in the decision-making process. And I guess this just gives you some insight into how we move through that process. Next slide, please. So what we do then is once a year at the moment, because we're on an annual planning cycle, we have a prioritisation process. And what this potentially does is takes all of the projects that we've got on the table that have been, born out of different areas, and we take them through a scoring mechanism, scoring against a set of different criteria. And then all of that is funneled into a prioritisation group that meets 3 times, and we review and prioritise against the spend that we've got and the priorities of the organisation. This has got obviously, again, quite a lot of detail, but it's more to demonstrate that there's a process. And as part of that, certainly for schemes that have been funded non-recurrently, so we always have a set of projects that are funded non-recurrently, we expect a post-implementation review to come through of that particular scheme, and then that feeds some of the decision-making that we make, that we do through that prioritisation process. And really where we're trying to land the rapid evaluation tool is as part of some of these structured processes so that we can ensure that it's incorporated into our decisions. Okay, next slide, please. So as you can imagine, there's a lot of intelligence that's required to drive that process. And I guess this just articulates some of that intelligence that the intelligence team in the CCG tried to generate. I did this slide about a year ago for another presentation, and I kind of rag scored us against how good I felt we were on different areas. And really, we're very good at describing the problem. So population segmentation, health needs assessments, benchmarking our spends and outcomes. We kind of do that. We do that a lot, and we often re-describe problems. I think you can always improve in nuanced areas, but I don't think we're bad at that. We're not. I was going to say we're not normally very good at modelling service impact and service change and scenario planning. However, COVID has really seen an acceleration of that, and all we seem to do at the moment is capacity planning and service planning about what might happen next in our services. Coming round then to the very other side, I would have said a year ago we weren't very good at evaluation. So it's always like a poor relative to some of the other, analytics that CCGs can produce. And, there's lots of reasons for that, but predominantly is because it takes time, and we never really seem to create time. That would be my observation. So where we've got some good examples of evaluation, it's where we've allowed ourselves to step back, find decent partners to work with who are good at it, and then have taken the time to move through that process. And really, that's where I think the RICE project sits as part of that evaluation piece for us to try and improve our evaluation capability of the CCG. RICE is quite niche, so it's only a specific part of an evaluation process. There are other ways that you can evaluate services, but it's a very, it's a very welcomed part of the evaluation process, and I'm sure we can get into the detail of why that is shortly. Next slide, please. So a little bit about the data sets that we have. So the RICE tool, the rapid evaluation tool, which Ben will talk about exactly what it does, it builds its evaluation of patient level data. And I suppose very briefly, it looks at the position of the impacts of an intervention pre and post. Pre and post, and compares that to control group pre and post. Now, in order to do that properly, we need a good patient level linked data set, and this is probably something that's been quite close to my heart throughout my career. Really, I started in primary care as a facilitator about 15 or 20 years ago now, and came through the analytical route and really saw the value in some of the primary care data. And as I've come through the process, I've kind of brought the data with me. But what we've done over the years is built this patient level linked data resource to enable to run some of those analytics. And this is just describing some of those data sets and kind of that process. So across the top, you can see the different data sets that we have. that they flow partly into NHS Digital with the exception of the primary care data, and then they come back out to us in pseudonymised form. And then what we've got is different data processors, including ourselves, that are able to look at that data and produce analytics to inform CCG business. The 3 data sets that I think are really useful and important are the primary care data, as I've said, and we had to work quite hard to get that, and I'll talk about that shortly. The other really useful data set for us is the advice on prescription data that you see in the middle there, that describes the socioeconomic determinants of health and gives us a really rich resource to understand people's social circumstances. And then the other one that was really useful is the adult social care. And they were the 3 that we really had to work quite hard with partners on to flow in order that we had a comprehensive data set to evaluate some of our interventions. Next slide, please. So the current access and information governance, again, this is technical, but maybe some people in the audience are thinking, how do we arrive at a position where we've got that linked data set? I probably won't go over to this too much detail, but afterwards, if anyone wants to contact me to understand the information governance framework, because that's often something that's tussled over in terms of having these data resources, then, I'm happy to describe the detail. But essentially, we've got sharing agreements with NHS Digital. We've got sharing agreements with each general practice in the city to allow them to share their primary care data. We've had that for about 10 years, but what we had to do is build a lot of trust with general practice in order to build that up. And then we have other sharing agreements. So they name processes and they can be amended if we want to add flows. And then what we've started to do is support what we call some research and action, which I think RICE tool is one of those, and the Health Foundation grant that we got to complete the RICE tool. That essentially what we've done there in terms of governance is we've offered a data scientist in Ben's team, Roberta Peraldi, who's done a lot of this work, an honorary contract with the CCG. And then that gives her the governance to be able to access the data on behalf of the CCG to undertake the complex analytics. Next slide, please. So what are the ingredients? Because I've been asked in the past, how have you managed to kind of get there in order to have this arrangement where we've got the expertise and the data to be able to do, the analytics? And the biggest thing I would say to that really is the relationships mean everything. Like, we don't get things done without people. And there's probably 4 key relationships which I've given a nod to on the previous slide, but one of them was the relationship with our local medical committee in primary care, and really to get that primary care data flowing and utilised, which is kind of the cornerstone of any analytics that we want to do. We had to really work on that relationship and the trust between 2 organisations. The other one was the relationship with the City Council in order to flow the social care data. We're lucky in Liverpool that we have got quite a strong joint commissioning relationship, and I kind of basically piggyback on the back of that to find the right people in the City Council and kind of sell them that, this vision that we can arrive at this data resource together and it would be mutually beneficial. And then the third one is with our desk row. So that's NHS Digital. Essentially, we've got a very responsive local team who kind of recognised that this was important to us and really helped us move that forward and almost challenge, centrally NHS Digital on some of their processes and their governance to get us to this position. And certainly, for people in the audience from a CCG, the desk rows have moved on a lot more than when we started this. So a lot of this data source now might be all readily available. I think the other ingredients then is definitely the vision and the leadership. I think you've just got to be quite tenacious and just keep going. And I think I basically just got on everybody's nerves for ages. And it's hard when you've got the day job and that's capacity. I've listed that at the bottom, but you've really just got to stick at it and keep going. A common view on information governance was the really most difficult part, to get that data resource together, because it's not black and white and organisations had different appetites for risk. So we had to do a lot of work to sell the benefits, and it wasn't necessarily just about proving the legal basis, because some of this was hearts and minds, I think, on the information governance, and obviously needed to be underpinned by more black and white governance. But that was one of the most difficult things. And then you need the detail. So you need people to kind of sell the vision and leaders and all of that, but you need analysts beneath you who can actually deliver some of the complex, data linkage and do the actual, the real work. And they need to be quite responsive, which is where the relationship with the universities really come into play, because they've got the expertise and we need that expertise. So to kind of strike up that relationship with Ben and his team was really, really important. Next slide, please. So Ben's going to talk a little bit now about the actual tool and what it does, and then I'll come back in and say how we've tried to implement it within the decision-making process that I've just described.
Next slide, please. Thanks, Helen, and thank you, everyone. Welcome. So obviously, you know, the really hard work was getting the data together, as Helen has outlined. And then our challenge was to try and use those data to understand whether particular interventions had worked or not, whether they'd had the expected impact on some of the outcomes that the CCG was interested in. And to do that in a way that we could then kind of reapply those methods fairly rapidly across multiple interventions and repeat the analysis on the same interventions as they evolved or changed. So I'm going to talk a little bit about some of the general methods that we've used in doing that, and give one specific example. So, I mean, we call it a tool, but really it's a set of scripts and guidance that analysts can apply in using the data that Helen's outlined. So the first job really was to get the data into a form where we could track the trajectories of people who had or had not received given interventions. So deriving a cohort of the whole population of Liverpool with kind of monthly records on each individual as related to particular events in primary and secondary care, as well as mortality data and other outcomes. And then within that cohort to be able to then flag whether people, when and whether people had received particular interventions. And we started off with a sort of long list of different interventions based on investments that the CCG had made over sort of recent years. And then, so we got the data on being able to flag when people had received those interventions within that data set. So the major kind of issue methodologically of trying to estimate the impact of an intervention is to get some kind of estimate of the counterfactual. So what would have happened to the cohort of people going through that intervention if they hadn't received the intervention? And obviously we can't know that. So our best estimate of that is to try and compare outcomes in that intervention cohort to a group of patients or people, members of the public, who are similar in all the ways that we can measure within the data. Obviously the intervention is not being randomly allocated, so there are always going to be some differences between those groups that we can't measure that are going to be a source of bias. We can try and minimize that bias, but we can probably never get rid of it completely. So there are really sort of three ways we can use, methods we can use to try and construct that control cohort. We can use matching. So we can, based on a set of characteristics, we can match the intervention group to people who are similar on those characteristics using a method called propensity scores. Or we can use weights. So we can basically weight the population that haven't received the treatment based on how similar they are to the population that have received the intervention. Or the sort of third way is to use a combination of those. So we can match people who are similar, but then also apply these weights to account for any sort of residual differences between those groups. And that we basically apply all three methods and look at if there are any differences in the results based on those different methods. So next slide, please. So our basic method once we've got those kind of two groups to look at what the impact of the intervention is to look at the change in the outcomes that we're looking at in the intervention group before and after the intervention, and in the comparison group before and after the intervention, and to look at the the difference in those changes. There's a method called differences in differences. So looking at whether how outcomes have changed in the intervention group relative to how outcomes changed in the comparison group. Obviously, we're quite limited by what outcomes we can look at in these data. Most of sort of health service data doesn't really have kind of outcomes exactly. Most of the measures are related to people's use of health services. We don't have many measures of how people are feeling or people's quality of life. So the outcomes that we look at are largely related to service utilization, for example, unplanned emergency admissions. Next slide, please. Yeah, so that's just showing that the effect that we look at is this difference in differences. Next slide, please. So the first intervention that we looked at was a model of integrated care. And this is very similar to models of integrated care that have been introduced in lots of places across the country. And there's been quite a few studies looking at the effect of such interventions. Involved kind of multidisciplinary teams, direct referral into those teams, and a plan of sort of care planning with those teams with goals and review. So that was the first intervention that we looked at, and the main outcome that we looked at in relation to that intervention was unplanned hospital emergency admissions. Next slide, please. So this just shows the trend in emergency admissions amongst people who received the intervention and those who didn't. So on the bottom, that's the intervention cohort, and it looks kind of quite positive that the admissions drop off after the receiving the intervention, but that could be just due to an issue that is called regression to the mean, that we've identified people that had high admissions, so just by chance they will fall off over time. Next slide, please. So we matched that to a comparison group across a whole set of risk factors, and this just shows a comparison to those. And we basically get a group of people who are very similar on everything that we can measure, apart from that they haven't received the intervention, and that they have very similar trajectory of admissions before the intervention time point. Next slide, please. And then we look at comparing the trend in admissions between the intervention group and that comparison group. And that's what's shown in this chart here. And we can see that kind of before the intervention time point, they have a very similar trajectory in terms of admissions. And there's not really much change after that time point. And we then run this series of analyses, some using weighting, some using matching, and some using a combination of them both. And basically, those all sort of fairly consistently indicate that there was no association between the intervention and an effect on emergency admissions. Next slide, please. And we also looked at mortality, so survival amongst the intervention and comparison groups, and similarly find that there was no impact on survival. So the people who were receiving the intervention and the comparison group had equal chances of survival afterwards. Next slide, please. Then the findings kind of indicate that we can't find the intervention appeared not to have an impact on hospital admissions or mortality. But of course, that doesn't tell us whether it had an impact on other important outcomes, or that it might have had an impact over time, over a longer time period. And it doesn't really tell us about why it did or didn't have an impact. And these services are constantly evolving, and that particular intervention did changed provider and some of the service model in 2018. So those changes may have had an impact that we can look at in further analysis. So it does give an indication whether in this particular outcome, whether it had an impact, whether it's rapid enough to feed into the commissioning process that Helen outlined is another issue, but potentially as now we've got those systems in place, we can turn that analysis around much faster to look at the ongoing impact of those services to feed into that process. And I'll hand back to Helen.
Thanks, Ben. Next slide, please. So just a bit about the so what. So next slide, and this is the last slide. Were we successful in embedding have we been successful in embedding rapid evaluation in the decision-making process? I'm going to sit here and say no, there is more work to do. We've got the tool now, and obviously there was a lot of development work that went into that, but really there's some key areas that we need to now really work on. So one is that we need to run more evaluations of different areas of service and spend. And every year we make decisions about which services we roll over. So some of those decisions need to inform which areas we need to evaluate. So we've got kind of a list. Some of it's been put on hold because of coronavirus. It's affected everybody's BAU, hasn't it? So, but we have got a list, a waiting list, should we say? The other thing is we did manage to do a little bit, it was always our intention to kind of interview decision makers, and with the dual purpose of kind of educating them on the methods as well as understanding how we could best embed the methods in the decision-making process. We managed to do a bit of that, but again, with coronavirus, people have been distracted and taken off to other things. So we really need to kind of revisit some of that structure that we put, that we intended to do. We've got to raise practical awareness of the methods and results in the planning process that I described. I'd say that there's a handful of people at the moment who kind of appreciate the work that's been done in the background, but I wouldn't say that we've kind of whole scale embedded an understanding of what we're doing. We had a really interesting meeting with the provider once we'd sort of, undertaken the particular integrated care intervention, and they totally, it was interesting actually because the clinician that was on the call really understood the methods and he was quite excited about the approach. However, there was some issues that they had over the fact that the model had moved on so much. They were worried about the results being published and what it said about their service. And that, I think, comes back to Ben's point around the context of describing what this particular piece of information is telling you and what's missing from that, so that people don't jump to a conclusion and then make, a decision solely on the basis of one piece of information. And also then we've got to work harder on embedding the evidence in the decision-making process, which I feel personally I'm quite well placed to do that as we run that decision-making process, but it's just about us doing the other points on the slide. And I'll finish there on.
Perfect, thank you very much. So before we jump straight into Q&A, just want to remind people that if they do have any questions for Helen or Barr or Ben, they can use the comment box underneath the live stream to submit those. There's a couple of questions already coming in, and I've a couple of questions myself as well, but some of them are sort of really clarifications on sort of the detail that Ben presented. So I suggest we kick off with those, and then we come back to sort of the discussion around how evaluation sort of informs decision making. So the first question I'd like to put to you, Ben, is quite a specific one. It's from Christina from NHS Greater Glasgow and Clyde, and she's asking, if doing a difference in difference analysis, how do you determine the intervention date for those not receiving the intervention?
That's a good question, and one that I kind of glossed over in the presentation. So what we actually did is applied a random intervention date to all of the people who hadn't received the intervention, that was based on the same time distribution as the intervention had occurred. So we basically just randomly allocated a kind of placebo date across the whole of the rest of the population, and then used that as the intervention date for those people.
That's really helpful. I think it sounds very similar to some of the methods we use. Just a quick follow-up. Do you re-enter people at different points in time, or do you use the whole population and therefore you just assign one random date?
Just one random date, yeah.
Right. Another sort of quick follow-up, I guess, on the study itself, and maybe Helen has a view on this as well, but wondering if you, so this is a question from James Hayward from NHS England and Improvement, whether you would consider reduction in readmission a better outcome on sort of for integrated care interventions rather than number of emergency admissions. I don't know if that was part of your consideration.
For Helen or for me, that question was that.
Sorry, you dipped out then a second. Sorry, say that again.
So the question was, so I think that the work you presented on the integrated care systems, you looked at emergency admissions. The question is whether you considered looking at readmissions instead, and maybe that's a better indicator.
Did we? I don't think we did. So no, and maybe that is a better indicator. I think it's quite difficult to kind of get the time frames, and I don't know whether the Ben might need to help me with this, but I don't know whether the confidence intervals become quite low because your volume of readmissions is quite a low number, if that makes sense. It's only normally about 10 to 15% of the original cohort. So I think that would be more complex, if that makes sense. But it could easily, I think we'd have to think, it's a possibility.
Yeah. I mean, I think it's definitely sort of worth looking at. I mean, I guess it is a bit difficult to define what is a readmission within that. I mean, basically, the admission rates in the intervention cohort are very high. So pretty well, most of the intervention comparison cohort have had an admission, recently before they enter the service. So we're looking at admissions after that point. So
I mean, in effect, you're kind of already looking at readmissions, but I suppose when we're saying this is we're going to put a time frame around it because everybody will have had an admission by back to the selection criteria. So I guess what we're saying is we would put a constraint to say, well, how many within so much time? So 30 days is a common one, isn't it?
Okay. So another technical question, but also, I guess, a wider point from Lee Ten at the Victorian Department of Health and Human Services in Australia. It says sort of do you do the propensity score matching and weighting using a standard set of fields every time? Or does this differ by program that's being evaluated? And the follow-up question there in particular is this person is curious about how reusable or standardized sort of the scripts are that you use as part of the RISE tool to sort of help the rapid element of the evaluation. Do you want to give a go, Ben, first?
So I mean, the first question, we would look at different characteristics and criteria potentially for different services. I mean, the first thing was to really understand what are the eligibility criteria for the service, so for the integrated care. So you want to make sure that you're including factors that are specifically related to the population that service is targeting, but then also kind of based on people's sort of experience and sort of published evidence, things that are likely to be related to the outcome. So for a different service, for a different outcome, then we would be looking at different characteristics.
Yeah, and I would say that we kind of did that as a group, where we selected those criteria with clinical input and the evidence review. So it was much more of a, it was a discussion and agreement. But another example of an intervention that we would want to evaluate would be that advice on prescription service. Well, actually, then the characteristics of individuals who get referred into that are much more kind of socioeconomic in relation to the intervention. So it would be right then that we were picking people with, similar criteria across interventions, because you would end up with a cohort that wouldn't necessarily be matched for the right reasons, if that makes sense.
Yeah.
Yeah, no, it does. Yeah.
Of how standardized the kind of scripts are and packages that we've written for that. I mean, it does, at the moment, at least anyway, it does involve a reasonable level of sort of technical competence for the analyst to be able to apply that. But where we can, we've tried to shorten the amount of work that's required in kind of developing the analysis for a new intervention. I mean, the thing that's most time consuming is actually kind of constructing that cohort in a way that makes it's easy to apply that analysis and keeping that as a sort of live kind of cohort. So that bit of work obviously has been done and can be applied across all evaluations.
Great, thank you. There's quite a few more questions coming in, sort of around some of the technicalities, but there's some broader questions I'd like to get to as well. So I suggest maybe some of these questions we can sort of pick up into the discussion more later, or I might come back to them depending on time. Before we sort of go towards the decision making, I have one final question, which seems to get quite a lot of interest, which is from Camille from the Nuffield Trust. She'd be really interested to hear more about the experience of linking adult social care data sets, and in particular, understanding a bit better what sort of information is included within that data and whether that covers self-funders as well. She mentions that in previous evaluations, she's really struggled to obtain sort of a comprehensive overview of social care services because there's so many providers as well.
Yeah, and so I don't think it does contain self-funders. It is just commission provision from City Council. And so I suppose that was one of the ones, the information governance has got a lot easier on that in recent years, but we were kind of at the forefront in terms of being able to flow the data that did exist in Liverpool City Council into the CCG initially, because I think it's an information governance question really, isn't it? So initially we had a local flow, and so it was pseudonymized at source and it was sent over to us for linkage. So because we didn't have permissions to see the identifiable data, and that was something we negotiated with our local city council. But then we also did a project with NHS Digital to essentially put the information governance framework in place that it could flow via those. And now there is a protocol in place with them based on the Liverpool, and I think Manchester were involved in that project a couple of years back. So there is the ability to flow it in and out of NHS Digital now, which then opens up that ability for other, healthcare systems across the UK to be able to tap into that governance by just amending their DAR or something and doing a DSA, but replicating essentially all the information governance that we put in place for ours. So that got us the flow, but the flow is it's contact referrals, assessments and outcomes for people receiving social care.
Right. And
that's all we have at the moment. We are trying to work on a children's data flow, but there seems to be different governance
Yeah. That's really helpful. Thank you very much. I've got an interesting question as well from Nicola Irvine from the University of Strathclyde. So she says, getting clinical teams on board, especially in identifying local leadership, is a challenge for anyone leading an intervention evaluation on the front line. And she noticed there are very few clinicians at this event. So she was wondering, how can this type of imperfect research gain wider recognition in clinical teams who are very heavily influenced by the EBM-RCT, this randomized control trial, philosophy of research, and skeptical of the sort of qualitative aspect of such work. Ben, do you want to kick off on that?
In terms of the clinical engagement, that's really something that Helen and colleagues have brought on board, and we had kind of good engagement, particularly from GPs in the startup of the project. So they've had an interest in it from the start. I think one of the things around the kind of different kinds of evidence and how different groups are kind of convinced or not by different sort of types of evidence, I think is really sort of an issue. And one of the things that we found with this, particularly when you've got a sort of matched group, because it looks a bit like the kind of analysis you might see from a trial or whatever, that some of the clinicians kind of are sort of more familiar with sort of looking at that, and that does seem to mean that it kind of is potentially more influential with some of those groups than other forms of evidence. I don't know if Helen probably has some more thoughts on that.
Yeah, and so I think there's I certainly know our clinician isn't on this telephone call because they're busy vaccinating people. So I don't know whether it's a symptom of where we are. I mean, the clinical teams are incredibly busy on the front line at the moment. In terms of more, from a generic perspective in our particular project, in the CCG, we have what's called a clinical forum, which is chaired by our deputy chair, and that's all of the GP and all the clinical leads basically meet once a month, and we really tapped into that as a way of kind of engaging them in this process. And they were quite receptive to the kind of the nature of the evaluation, because they enjoy statistics and they enjoy that type of evidence, don't they? So I'd say that there was clinical engagement where there was time to get it, and I would say the biggest constraint was actually being able to get their time to input into the process, because everybody's always quite busy, but they were certainly, I wasn't surprised, but they understood the methods obviously, and that bit wasn't difficult, if that made sense, and so for me the clinical engagement was less, I'm going to say, of an issue. My bigger challenge is more how we get clinical input into the planning process, so that when we do use the evidence to make the decisions, if there's clinicians around the table to do that, and we're kind of working on that at the moment. But I would say that they were pretty engaged, but that's obviously a very kind of local specific. Yeah.
No, that's really helpful. Thank you. I'm just going to abuse my chair's privilege and ask a question of my own, because you mentioned that sort of clinicians are quite, to some extent familiar and interested in these sort of more robust statistical methods. So, Helen, I was wondering whether you think that sort of policy and decision makers or working with you, colleagues of yours, also value this more robust approach to taking the more robust approach you're taking to evaluation, and whether they sort of value that over and above sort of maybe the regular reporting they're used to with sort of trends over time.
I think they have to. If they don't, I'll tell them they need to. But no, I mean, genuinely, I think they do. I think it's just about getting it into the process. So obviously normally we would say admissions have gone up, admissions have gone down, and we would be making decisions on that basis. And in fact, we still do in some areas, along with other, evidence as well about particular interventions. But they absolutely value a move towards a more robust approach. I think they're genuinely interested in what it says, because, things like, does integrated care have an impact? These are big questions, aren't they? So I think they are quite genuinely interested in what this new approach brings. And in particular areas, so I know end of life, there's a steering group, and the clinical lead was like, we need to do this for our impact model, which is a change in service for people at end of life, and also for telehealth, because Liverpool's quite at the forefront. We've had a massive telehealth programme for about 4 or 5 years. They are absolutely valuing this different way of looking at things. I'm a bit worried moving forward that with coronavirus and the change in service utilisation that we've seen over the last year, and I don't know whether some of this was covered yesterday, but it's going to really impact on our ability to get a meaningful result, because it's just been so volatile. But I think we're just going to have to find ways to account for that moving forward.
Yeah, I think that's a challenge that a lot of evaluation teams will be facing. I think, as Ben described, sort of having the intervention group and then looking at those patients not exposed to the intervention, assuming that represents usual care. I think with what's happening over the last year or so, I don't know if there is a definition of usual care that we could actually actively rely on, and to what extent there is that impacts on on the control group. I don't know, Ben, if I'm sort of putting you on the spot now. I don't know if you've thought about that at all going forward.
Yeah, I mean, I think it will be a huge challenge, and it's not something we've looked into in detail yet. I mean, in theory, you're potentially comparing. Your comparison group and your intervention group have both been affected by those changes, but it depends on whether those effects are likely to be similar across different groups, and obviously the interventions have all changed. So it's things that were working beforehand might not have worked in the current context, and new things that other things that maybe weren't working may work better within the current context. So there could be differences in the effect of the interventions based on those changes in the way services are being provided and the wider context of public health.
I suppose to pick up as well on the original question, I think one of the challenges the clinicians have noted when we've come and talked to them about the evaluations that we've done to date and the ones that we're going to do is really that in the real world, you've got to make decisions at certain time points, and often you can't generate, even though we call it rapid evaluation, the process might be rapid once you've got the time, once the time period has elapsed, but it's quite hard to generate results in a timely way that enables you to then inform the decision that you need to make, because you're bound by the operational planning timescales that you need to hit around decisions of what you invest in. And so the impact model, as an example, is an end-of-life intervention that was undertaken kind of just before lockdown in last March, between January and March, and actually not quite enough time has elapsed for us to be able to say, here's the impact of that. And I think that the clinical decision makers then find that a bit frustrating, because ultimately we're going to have to make a decision on whether we fund that moving forward without actually having this robust evaluation. Now, it will inform a future decision, so it's not lost, but the timing isn't always in our favour when you want to do proper evaluation.
Yeah, no, that makes sense. I've got a couple of questions specifically around the data sets actually that are included and that you have access to through the RISE tool. So I don't know who's best placed. I'll start with a question from Daniela Rodriguez from the Imperial College London. She's wondering if it's possible to talk a little bit more about the data set that includes socioeconomic and other more social information that was mentioned. I guess trying to get an understanding of what's captured in that data set.
Yeah, so it's a local data flow. It's not a standardised national data set, and it comes from the Citizens Advice Bureau, who offer interventions for our population, for people who have socioeconomic hardship. So it's got things like their income, their things, lists of things that they're struggling with around their socioeconomic status. And then also they offer brief interventions. So that might be maximising income capacity, or it might be, pointing them to onwards, social prescribing type signposting. And they then also record in there the kind of outcome of the interaction. So whether they then felt better about, their particular status, and there's quite a bit of outcome data in there. So it's moving us more towards what I would say a true outcomes data set. It's only for the people who've obviously interacted with the service. So it's quite difficult to find a control cohort necessarily, because we wouldn't necessarily have the same socioeconomic information for a control group. And so I think that's going to bring with it new challenges. And we probably need to look into the GP data to see, because we do not have that for everybody, to see what might be a common variable. But some of the socioeconomic variables that we might want to use to match probably won't exist in the other data set. So it is something that we're just going to have to try and think about and rise to that challenge. There's other ways, though, to just use that data to evaluate the intervention, because it's got outcomes data in. You might not necessarily have to do this statistical method when you're looking at actually what that service delivered.
Yeah, that's really helpful, and it's really interesting. You've got such a rich data set, because I think nationally, the most commonly used data set, I'd imagine, is the index of multiple deprivation. Yeah. I don't know, Ben, if you're aware of any other national data sets that capture more detail.
Not really. I mean, that is one of the things that we really struggle with in the health service data sets. I mean, even the sort of coding of things like ethnicity, which of course has always been a major issue, but has been kind of highlighted in the current pandemic. That is often not very well complete in health service data. Yeah. But locally, the Liverpool City Council has also brought together a sort of set of data sets as part of the sort of response to COVID-19. And we're looking at ways we can link some of those data sets with health data to get a better view of the socioeconomic circumstances across the whole population.
I think pre-COVID, because then we all got busy, we did quite a lot of work trying to identify, other places across the country really that had managed to do that full linkage, to the benefits and data as well. And it has been achieved by a few places. And we were on a journey to try and achieve that for our population, which would then give us a much richer data source. Obviously, information governance being the main, discussion point on that. And it is something that we probably need to pick up again now. And we lost a bit of momentum with it because we've all been distracted.
Yeah, no, I appreciate that. Helen, you mentioned that the data set you just described includes some information around social prescribing as well, which links to a question from Cindy Mann at the University of Bristol. She was asking if you could say a little bit more about the advice on prescription data, and she is wondering how that is collected, but also whether that includes something like social prescribing, or whether you might get that from the other data set.
So it does. I suppose it depends on your definition of social prescribing, because the intervention in of itself is almost like a social prescription, isn't it? So it's the Citizens Advice Bureau database. So a lot of it might be commonly available, but essentially it includes information on people who've been signposted to the Citizens Advice by their GP because they have some kind of either financial or other social hardship. So the social prescribing data is kind of that is the intervention, if that makes sense. That's the social prescription almost. So a GP, has a consultation with someone, they express that they've got some other social issues, and the GP kind of gives them a referral into this service. And then the data that we collect from that service is the data on that intervention, which then might be they might onward signpost to other services. We don't have that data, if that makes sense. So we only have what's contained in the Citizens Advice Bureau database.
Yeah. Okay, that's really helpful. There's a few more questions, but I think we're close to running out of time, and there's a couple of things I sort of was keen to cover. So I've got one final question for each of you, I think. Ben, I was just interested in sort of your role, particularly within the RISE project, and sort of how you see your role, sort of an independent academic, I guess, working closely with the health service, particularly where I think more often than not, sort of NHS analytical teams want to bring in sort of evaluation capability in-house. I'm just wondering sort of, what you see sort of your role as an academic in supporting that, as well as sort of obviously your own academic work.
Yeah, I mean, this project has had a huge influence on the way that we work, both at the university and how we then intersect with Liverpool CCG. So we have now a few data analysts who are now co-located with the business intelligence team at the CCG, and it's really sort of changed the way that we work. In that we're sort of, rather than it being academics kind of trying to access data for their sort of particular research projects, it's much more of a sort of joint initiative where we're both supporting the kind of operational needs of the CCG, but also then looking at how that can be utilized for sort of wider research objectives. And that really has enabled us to be much more responsive in terms of developing research that's delivering better on the kind of needs of the local health system, and that really has sort of led into much wider work, kind of bringing together data and analysts across Cheshire and Merseyside as part of a kind of joint initiative supporting the response to the pandemic called CIFA, the Combined Intelligence Public Health Action. So it's really has kind of it's led into a kind of way of working that's much more joined up across the health and care system, that basically enables us to do much better research because we're better responding to the needs locally, but also helps us deliver work that's much more useful as well, and in a more sort of timely manner. And it's also led into a number of different sort of research grants that has brought in more resource to the system as well.
Thank you. That's really helpful. Final question then for Helen. I think you mentioned sort of you'd like there's more to be done to really make sure sort of these evaluations sort of inform the decision making and sort of build up that link. And I appreciate sort of COVID has been sort of in the way of developing some of that as well. I'm just wondering if what you think are the one or two sort of key learning points, if there are other, if there's people on the sort of attending the conference who are thinking about implementing something similar in their local health system, where they want to make sure sort of decisions are really driven by evidence.
So I'd probably refer back to this one of the slides in my email, really, but I would just say like relationships are just key. So find the people who do the stuff and who can, because there's people in organisations who are placed, who get to the nub and help unblock some of these things that you need to do. So I think one of my biggest things is saying, find those people and, generate an interest, galvanize them to do the things that you need them to do in order to realize the vision. That would be one of my biggest kind of pieces of advice. And yeah, it's kind of just I feel like for Liverpool, it was a bit like the stars aligned, if you know what I mean. Like we were quite lucky that was in every part of the system where we needed it to be, people responded to kind of the ask. So yeah, I would say that. And then I think a lot of it is about, I do think to get there, it's about having that kind of leadership and vision. And that might be about then getting, quite senior champions on board at a local level. But as well as, you need to find the doers too, the people who can get the people who've got the expertise and can get into the detail. Yeah. So yeah.
People.
Yeah,
perfect. Thank you very much. I want to thank both Helen and Ben for taking the time to sort of come and talk to us so we can sort of learn about their experience with all the incredible work they've done in Liverpool, particularly in these current times where there's a lot going on, a lot of pressure on the system. So I very much appreciate it. Thank you very much for your time. We're going to break for 10 minutes. The second session of today will start in 10 minutes. It's at sort of 20 to 11. This session will focus on how rapid evaluation sort of fits into a learning health system. And Sarah Blundell, my colleague, will lead that session. I would like to encourage delegates to provide feedback on this session if they'd like to. I think there's an option next to the live feed to click on some smiley faces. And there's also a further evaluation survey that you can find on the discussion wall. Just wanted to let you know that any feedback you do provide is anonymous and very much appreciated. There's some further questions that we haven't been able to sort of get to. There are a few of those we might be able to pick up in the discussion wall on the platform. So keep an eye out for that as well. And just thank you all very much and see you again in 10 minutes.